Welcome to the 2016 update on pain management. We have broken down this series into several shorter videos that you will need to watch to get credit for this course. These are the overall objectives for this course. First of all, we want you to understand the basic physiology of pain, how we receive it, how we process it, how we interpret it. We want you to understand that role non-traditional factors play in pain and pain management. We want you to understand and avoid biases in pain management. We want you to properly assess pain and apply that to your pain management plan. And we want you to understand and apply the Access and Ada County Standard Written Order guidelines on pain management to everyday patient care situations. This course was largely developed by J.D. Hendrick of the Meridian Fire Department. Given that, you're probably wondering why I'm giving this voiceover instead of J.D. Well, the simple answer is J.D. is a slacker. Instead of sitting here in front of the computer and giving you this lovely information that he developed, he decided he'd rather spend time up in McCall at the McCall Winter Festival with his family. I know it's hard to believe, but in retribution, I want everybody to send him an email and tell him what a slacker he is, hanging you guys out to dry to spend yet another lecture with me. Now, there are no disclosures to mention here. We're not partying of the studies we mentioned. We're not selling you anything. We're simply putting out an educational offering, and we hope that you both enjoy and absorb it. Here are some of the reference materials we used. If you're taking this through Target Solutions as a course, up in the reference tab that should be in a resource tab that should be in the upper right hand corner, we'll have most of these there for you to download. If you're taking this as a crew-based activity of some sort or another, then our plan is to make these materials available for your review as well. You can read these or not as you wish. There will be some of you that want to understand pain management and the context a little bit more, and we've tried to make all the information that we use to develop this course available to you. Now, according to the International Association for the Study of Pain, pain is an unpleasant sensory and emotional experience associated with the actual or potential tissue damage. Now, I want to point out one key factor is that this statement talks about not just the sensory, the actual noxious stimuli, but the emotional impact. And that we're going to talk about that. You're going to see it as a recurring theme throughout all the videos of this presentation, is that we're not going to just treat the injury. We're not just going to treat the pain response from that injury, but we're going to try to treat the patient that is suffering that. In doing so, I think you'll find that if you can implement some of these strategies we talk about, in doing so, you're going to find that that traditional stuff we use, such as ice therapy and pain medication, so on and so forth, is going to be more effective. It's not an either or proposition. So we hope we give you some good information for that. Albert Schweitzer said in 1931 that we all must die. But if I can save him, meaning the patient, from days of torture, that is what I feel is my great privilege. Pain is a more terrible overlord than mankind than even death itself. And this is true in a lot of different contexts. We know that in the discussion about torture and interrogation, that fear of pain will make people do stuff that even fear of death will not. Will make them make confessions to crimes they didn't exist and so on, that they never performed and stuff like that. So I guess that just shows the motivating and demotivating factors of pain in a variety of contexts. How often do we see patients with pain? Well, generally speaking, we know that about 50% of patients that present to the emergency department have pain somewhere as an issue somewhere in their presenting complaint. Not all are going to be for injury. Some are acute pain, some are chronic pain, chest pain, whatever. Pain is a major portion. We look in our own system, you'll notice that about 11.3% of patients out of 26,000 calls received some kind of pain medication. It's pre-split right down the middle between fentanyl and morphine. We will talk about why we may want to choose one or the other later on down the road. But what I find more interesting right now in this particular slide is that if 50% require or have pain as an issue, but only 11% got pain medication. What happened there in that other 40%? Now, at this time, I say, well, that's the emergency department. Is that number accurate for EMS? Well, several studies have shown that we average about 40 to 45% of people calling an ambulance for transport have pain somewhere in their complaints. Now, certainly, I'm not going to say that 50% of the patients we see need opioid narcotics. But I do think it's worth trying to figure out what's going on with that difference, that 40%, and seeing if there's anything we can learn from that. Some of those patients maybe didn't receive pain medication because their pain was relatively minor. Some may have declined it. Some may have had contraindications, such as head injury or hypotension or something along those lines. We'll see. Now, pain serves a purpose. It tells us if something's wrong for our body, such as appendicitis. It tells us if something's dangerous, such as a hot stove. And if we've already injured something, it helps us kind of guard and protect it while it heals. Now, the way we sense pain is predominantly that when you look at the traditional theory of pain, what we call the Cartesian theory of pain, pain comes to us via nociceptors. And nociceptors are basically nerve fibers, nerves, that are specialized to receive and process information, send it to our spinal cord, and then through our spinal cord to our brain for interpretation. This process is called nociception. Now, here's what's interesting about this, is that most of these are specific to a certain kind of stimuli, such as pain, or such as thermal pressure, thermal or deformation or pressure, or certain noxious chemical stimuli. If you've ever been sprayed with OC spray, like this gentleman in the picture here, OC spray, capsaicin spray, actually triggers a specific chemical nociceptor, which is why it's so painful and effective. Now, most of these nociceptors are silent, which means if they're not being actively targeted, ideally, they don't send any stimuli at all. This is why some neuropathic conditions, diseases of nerve tissue, sometimes trigger these when there is no painful stimuli normally. This is neuropathic pain. Some of these are polymodal, which means that they sense not just one type of stimuli, but another, where it's different chemical stimuli, maybe pressure and thermal stimuli, whatever, which is why sometimes we get mixed or confusing pain signals to different stimuli when patients have various neurological disorders. Now, this is the traditional Cartesian theory of pain. As you see there, somebody stubs their finger on a tack. Impulse goes up the nociceptors and the nerve fibers to the spinal cord, where it then, in theory, would process straight up into the brain itself and be sensed and interpreted, and actions would happen. We also know that certain reflexes, the spinal reflex arc, as the impulse hits the spinal cord, it also sends impulses back to withdraw from the painful stimuli. So we are actually withdrawing before our brain ever processes the pain. That's interesting. But this is not the full picture. We know that there's something that they're calling the gate control theory, and there's this theory of these neurological gates at the spinal cord. Now, what happens is that as the pain hits the spinal cord, the pain impulse, the stimuli hits the spinal cord, these gates can do several things. It can enhance the pain, make it more severe than you would anticipate for that stimuli. It can make it less severe. It can mute it altogether. And sometimes it can take non-painful stimuli and somehow confuse it and make it painful stimuli as it passes through these gates. The reason we mention this is understanding this, and we're not going to talk about much more, but understanding this explains a large part on why there are so many different neurological disorders that cause different types of pain that are very difficult to qualify compared to, oh, I broke my leg and it hurts. Whether you're talking about fibromyalgia, whether you're talking about other neuropathic pain disorders that you see with diabetes and stuff like that, this helps explain some of the complexity. Now, if we talk about all the different types of pain, in some general categories, we can classify as acute or chronic. Acute is sudden. It's usually associated with specific injury or illness that comes on with it, and it subsides with treatment. Chronic pain often persists beyond the exacerbation of the underlying cause. It's much harder to treat, and it's much harder to mitigate. Referred pain is sometimes a term we use when pain is actually from an illness in one spot, but the pain actually occurs elsewhere, such as gallbladder pain, or pain in your ruptured spleen, but you actually have the pain occur in your shoulder. We also sometimes see that with pancreatitis. Technically, you have myocardial infarction and you have chest pain from that, but we also have referred pain into our left arm or our jaw or our neck or our back. Basically, pain other than where the underlying cause occurs. Somatic pain is generally what we refer to as pain in muscles, ligaments, vessels, and joints, where superficial is mainly pain in the skin and mucous membranes, and visceral is what we normally call as deep pain. Typically, we refer to visceral pain as a lot of the pain that we have with abdominal pain. When we describe something as neuropathic, again, it's caused by damage, disease to the nervous system, rather than maybe an actual cause or injury or illness downstream. Now, this can be all sorts of weird sensations, not just pain. Pain itself, there's all sorts of different flavors of pain. So this can be tingling, burning, electrical pins and needles, very similar to what, can be mild, can be severe. Now, sometimes we talk about psychogenic pain, and it kind of has a negative stigma in emergency medicine. When we talk about psychogenic pain as being caused by mental or emotional, we think they're just faking it. And as we're going to talk about, there's certainly people that make stuff up. I'm not going to say that doesn't occur. We now know that the psychological aspect, the psychological facet of pain and pain management is rather substantial, and we'll talk about that. So lots of things can exacerbate pain. Fear, discomfort, anxiety over the situation can all make pain worse. We also know that the opposite is true, which is why I'm going to talk a bit about addressing the patient's fear, making them more comfortable, keeping them warm, and talking to them and engaging them, rather than just letting them stew in their own juices, focusing on the pain itself. All this is part of a good, full, complex, or comprehensive pain management strategy. One final type of pain we're going to talk about is phantom pain. And phantom pain is basically pain that's coming from a limb that is no longer there, is like what we see with amputees. The onset of pain usually occurs soon after the surgery, the actual amputation. And if it's going to subside, it usually subsides in the first 6 months or so. But sometimes people will have this pain and these issues for years to one degree or another. About 80% of people who have amputations will suffer some kind of this pain to some degree or another. And when we consider the recent wars and conflicts and our veterans who are returned to our communities with sometimes multiple amputations, I think it's important for us to be aware of this. Now, treatment of phantom pain, if we want to call it that, is pretty just like treatment of neuropathic pain and various pain disorders. It doesn't focus just on opioids. Yes, they can use opioids for the pain management, but they often will use NSAIDs. They'll use beta blockers. They'll use antidepressants. They'll use a wide variety. They'll use muscle relaxers. And they'll even use non-pharmacological therapies. They'll use massage, acupuncture, meditation, and even simple positioning of the patient, positioning of the limb can cause and relieve pain. So just because something very minor, such as massage or repositioning, will relieve the pain doesn't imply it's as severe, less severe, or more severe. It just is the unique nature of phantom pain and neuropathic pain. Now, some people have neuropathies that decrease the pain they feel. Most of this lecture we're going to talk about mitigating pain, severe pain, but some people don't feel pain as much or at all. And the most common, two most common ones that we're going to see are going to be diabetic neuropathies and people with partial or complete spinal cord injuries. The concern here is that they don't realize when they're injured, and they don't get the warning signals from infection and so on and so forth. And this actually, over their lifespan, makes them more prone to illness and injury, and shortens their lifespan, causes more health problems. So that will just food for thought. Now, there's a lot of biases when we look at people who suffer illness and injuries. And of course, I think we probably think of men as these big warrior types and women not so much. And so there's been plenty of studies over the years that talk about who tolerates pain better. And first of all, context matters a lot. So certainly the type of pain, the way it was suffered, the people around, all those factors, those contextual factors play a role. Research in the 50s, 60s, and 70s seemed to suggest that men were more tolerant of pain, because they were encouraged to be more stoic, where feminine stereotyping and cultural context seems to encourage that they would be more expressive of their pain. But is that true? Well, Mythbusters recently found women to be more tolerant of pain than men. So either A, these responses are changing over time, or B, and this is what I think is more likely, context matters. Competition. If this becomes a competition, it matters. I did a little informal cold compressor test, pain response test in my class when I used to teach the advanced class, and the women way outperformed the men, even though it is a competition. We had some pre-driven women. So context matters. Several studies have looked at this, and for example, people who are in more competitive professions, people who are in, professions or activities that pain is kind of an anticipated part of it, such as ballet, and so on and so forth, rugby. The context, the social and cultural context of that downplays both perception of pain and upplays or emphasizes tolerance of pain, where other contexts, social contexts, it may not. Now, pain, as we talked about, serves an important purpose, but also can cause a lot of problems. Not just, in fact, things hurt, but especially chronic pain. Pain affects the attention that a person can bring to bear on a situation. Pain affects their memory. And this is true not just in everyday memory, but also the ability to handle complex problems. It inhibits our mental flexibility. And I like to think of it as kind of like a computer. When you're in pain, you're dedicating a certain percentage of your resources of that computer to a certain task. When you're in pain, you're dedicating a certain percentage of your cognitive resources to keeping that pain in check and tolerating it. Over an extended period of time, this builds up our stress levels, cortisol levels, and causes health problems. So, what we're basically talking about here is that pain is more than just a feeling, the Cartesian theory, where if you have an injury or you have an illness that causes pain, it sends the impulse into story. Pain is about context. It's about the emotional interpretation of that pain. And that means that we can manage this contextual and emotional and psychological factors to improve our pain management. And significant strides have been made in understanding this, and both in how the body senses and interprets pain, but how we treat it over the past 20 or 30 years. So that pretty much brings us to the end of this first video. I hope you enjoyed it, and we'll see you at the next one.